Hello everyone. In this video, I am going to describe about conduction of normal vaginal delivery. Before going to it, you need to know the basic terminology related to it.
A normal labor is a series of events that takes place in the genital organs in an effort to expel the viable products of conception out of the womb through vagina into outer world. Whereas delivery is the expulsion or extraction of fetus out of the womb. Delivery can take place without labor as in elective cesarean section.
So, when do we know that the labor has started? The first and foremost sign is labor pain. A true labor pain is characterized by painful uterine contractions at regular intervals. The frequency of the contractions increases gradually. Intensity and the duration of the contractions increases progressively. It is associated with vaginal discharge called show. Formation of the bag of waters is also seen. There is progressive effacement and dilatation of the cervix and not relieved by enema or sedatives. When the woman comes to the hospital with all these signs, we'll admit her to the labor room. An ideal labor room should have these following qualities. All these articles and equipments are required for setting up an ideal labor room. Newborn care corner is also required for the care of newborn. After admitting the mother to the labor room, all these preliminary assessment needed to be done. Welcome her to the labor room, collect proper history, change her clothing into hospital gown, monitor uterine contractions and FHR, start with IV fluids, do PV examination, do partograph to find out the progression of labor, note the color of liquor if membrane ruptured, and instruct her to follow breathing techniques. After doing all the preliminary assessment, the articles required for the labor needed to be arranged aside to labor table. The articles required for the conduction of vaginal delivery are the follows. Before going to the articles, it is important to remember that aseptic technique needed to be assured while arranging the articles. 3 kits are required for this procedure: delivery kit, episiotomy kit, and newborn kit. First is the delivery kit. In the delivery kit, we need a sterile tray containing straight thumb forceps, tooth thumb forceps, straight artery forceps, curved artery forceps, scissors, towel clip, sterile pad, 2 gallipo, one containing normal saline and gauge pieces, sponge holding forceps, along with all the drugs. In the episiotomy kit, we need a sterile tray containing 10 ml of 0.1% lignocaine, episiotomy scissor, curved artery forceps, straight artery forceps, needle holder, suture material. In the newborn kit, we need a sterile tray containing cord cutting scissor, straight thumb forceps, straight artery forceps, and umbilical cord clamp. By this time, the mother needed to be prepared for the delivery of the baby. Once the cervix has dilated to 4 cm, the mother is officially in the active phase of labor. Along with rapid cervical dilatation, there will be the presence of rhythmic contractions which needed to be assessed. Once the cervix has dilated to 10 cm, woman enters in the second stage of labor, and labor becomes more intense and more rapid contraction is seen. By this time, midwife or obstetrician needed to get prepared for conducting delivery. Surgical hand washing needed to be done along with all the personal protective measures like footwear, head cap, gown, mask and gloves needed to be worn. Maintain lithotomy or dorsal recumbent position. Expose the area and give perineal care. Encourage the mother to give pushing effort which helps the baby to come out through birth canal. During this time, support the mother's perineum with sterile pad to prevent laceration or injury. With more pushing effort along with uterine contraction allows the cervix to dilate, which helps the baby's head to pass through birth canal and can be seen through vulval outlet. This process is called crowning. Crowning is said when the biparietal diameter stretches out through vulval outlet. During this time, the midwife or obstetrician will give episiotomy. An episiotomy, also known as perineotomy, is a surgical incision of the perineum and the posterior vaginal wall, generally done by a midwife or obstetrician during second stage of labor to quickly enlarge the opening for baby to pass through. Before giving episiotomy, midwife will inject 10 ml of 0.1% lignocaine to the perineal region. After the injection of lignocaine, an incision is made with the help of an episiotomy scissor mediolaterally at the posterior vaginal wall. Episiotomy can be given in medially, mediolaterally, laterally or J-shaped. Most preferable is mediolateral. Slow delivery of the head is accomplished by pushing in with pad on the right hand and applying pressure on the occiput with left hand. Delivery of the head occurs through extension. After delivery of the head, it is important to wipe the baby's mouth and nose. Head needed to be supported with both the hands. Restriction of the head occurs to the opposite to the internal rotation. Next is the delivery of shoulders. When the anterior shoulder reaches the pelvic floor, it is delivered by gently depressing the head downwards. Administer IV methogen 0.2 mg IM. Gently raise the head up to deliver the posterior shoulder. Next step is the delivery of the trunk. The forefingers of each hand are inserted under the axilla and trunk is delivered by lateral flexion. Note the time of the birth and sex of the baby. Place the baby on mother's abdomen to prevent hypothermia. Clamp the umbilical cord using 2 artery forceps. Cut in the middle of 2 clamp using cord cutting scissors. Wrap the baby in a sterile cloth. Show the baby's face to the mother and inform the sex of the baby. Clean the baby's face and body and hand over the baby to nurse or pediatrician for immediate newborn care. Make sure that the baby is received in a tray with sterile cloth on it. As soon as the baby is delivered, administer 10 units of oxytocin and prepare the mother for placental delivery. Thank you for watching the video.